graphical anatomy of inguinal region. And everybody, please look to the picture. What does it mean, inguinal region? As you remember, it is the part of the hypochondrium. Previous, my lecture was about division of anterior wall, layers of anterior wall. And if you remember, finally, in anterior wall, we described 9 regions, yeah? And last 3 regions, which is located in hypochondric region, we call right and left inguinal region and suprainguinal region, which is between them. If you will try to imagine this picture, you will see that these inguinal regions has tracks in oblique triangular shape form, yeah? This triangle, which is drawn in our picture. Friends, don't speak, please, listen. Okay, take the board. Now look everybody to this slide. Friends, why you make so much noise by just the taking of your bottle? Oh, listen me, please. Like the water, it is important for you. Look to the triangle ABF. Triangle ABF we call the inguinal region. What is the borders of this triangle? Let's refresh your knowledge. Don't try it, please. We studied it in previous time. Upwards, we have bispinal line, which is connected right and left anterior superior spines to each other. Downwards, we have inguinal ligament or fold. Call it how you want. And finally, from medial side, 2 options. You can say both is coincident. You can say lateral margin of the rectus. You can say continuation of middle clavicular line, or you can say imaginary line, which is connected free margin of the 11th rib with the pubic tuberculum. That's it. All these options will be coinciding to each other. All of them will show the medial border of our inguinal region. Layers of this hypochondrium we studied together. I told you that here fat is divided into 3 compartments. If you remember, below our umbilicus, superficial fascia has 2. Now I don't have the time to speak about it, but I will mention for you some important structures. If you will look in the picture inside of the triangle ABF, you will see small triangle CDF. Triangle CDF occupy inferior 2/3 of triangle ABF. And triangle CDF we call inguinal triangle. Minute attention. Let's say inside of inguinal region, in the level of the lower 2/3 of it, we have inguinal triangle. By the way, it is different from region only by 1 border. It is upper border. As you can see, it is horizontal line, parallel to the line bispinal, which is started from the border between upper and middle third of the inguinal ligament. Let's say you divide the ligament into 3 equal parts. From the border between upper and middle third, you provide it horizontal line. You can ask me why it is necessary. Simple answer, guys, because immediately inside of this triangle, we describe a weak place of inguinal region, which is called inguinal space. It's an inguinal space located not in all inguinal region, but only in lower 2/3 of it, which is called inguinal triangle. Now you understand what does it mean, inguinal triangle? By the way, we didn't discuss vessels and nerves, or we finished that in our lecture. We didn't finish that. So today I will try to give it for you also. So remember about it, please. Now, what is the inguinal space? Inguinal space you see inside of the inguinal triangle. Yeah, it is the fissura or triangular shape weak place, which is formed, again, you know, last time I told you, between 2 structural units. Upwards, we have free margin of internal oblique and transverse muscles. Downwards, we have inguinal ligament. The problem we draw together connected with non-connection of the lower 2/3 of inguinal ligament with this free margin. Upper 1/3, as you can see, connected with these 2 muscles. Lower 2/3 of inguinal ligament doesn't connect it, and it gives formation of the weak place. Why it is weak? Because these 2 muscles are strong. That is more than simple, friends. Let's say, remember this inguinal space, it is the space between roof and floor of inguinal channel. if we will add 2 more borders, anterior and posterior, instead of 2D space, we will have 3D channel. What will be in front of these structures? External oblique aponeurosis. What will be behind of them? Transverse fascia. Layer number 5. Now, remember, forever please, now we have inguinal channel, which has 4 walls, and which has special position, as I told you last time, from up to down, from lateral to medial, and from inside to outside. If I will make now tube from my register, I can put it immediately in position of, for example, my right inguinal channel. You can see that it passed from up to down. You can see that it passed from lateral to medial, and a little bit from deep to superficial. Let's discuss now the rings of this channel. Both I draw for you previous time. Superficial ring forms by 4 structures. First of all, splitted inguinal ligament. As you remember, it is split into 2 legs, yeah? Upper medial, lower lateral. One is fused with symphysis, second with tubercle. Upwards we have intercrural fibers. Downwards we have ligamentum reflexum. That's why these 4 structures together forms the only shape, structural unit, which we call superficial ring of inguinal channel. For the males, as you remember, it made communication between scrotum and the channel. And by this aperture for the males, spermatic cord is passed, yeah? And it goes to the scrotum and connected with the testis and provided supplement to the testis. And evacuated the sperma from the testis into the urethra by ductus deferens. What about females? Round ligament of the uterus, it's down to the pubic bone and fused with that. That's all. But now attract your attention into the deep ring. Again, remember this 3D picture of our inguinal channel. And as in previous lesson told you, if you will imagine that this wall located in the back wall, and it will be open. What is my back wall? Transverse fascia. Let's say this wall perforated approximately 1 centimeter above and laterally to the midpoint of your inguinal ligament. Let's open again the picture. Let's measure approximately midpoint of your inguinal ligament. Let's go 1 centimeter up and 1 centimeter laterally to this midpoint. 1 centimeter above and 1 centimeter laterally to the midpoint of your inguinal ligament, transverse fascia is perforated. And this perforation is happened in the embryological time, and in my previous lesson, I don't remember we discussed or not, but it's happened during the process which is called descending from testis. Let's say then testis is descending from up to down and from inside to outside, together with vaginal process of the peritoneum, which I will explain you today. It is consequently perforated 3 structures. First of all, transverse fascia, and it forms the deep ring. Then it's perforated these 2 muscles, internal oblique and transverse, and disconnect them from lower 2/3 of inguinal ligament. It forms the space. And finally, it is reached to the external oblique aponeurosis, press it, split it into 2 legs, and forms the superficial ring of the inguinal channel. Let's say once again, remember please, what is the deep ring? It is aperture, it is defect in the back wall of inguinal channel, which is located 1 centimeter above and 1 centimeter laterally to the midpoint of inguinal ligament. Now you have complete structural unit, which is called inguinal channel, with 2 rings and with 4 walls. About content of this channel, also not puzzle, guys. For the males, only 2 structures. One is thick, second is thin. Thin one we call inguinal nerve. Inguinal nerve, primary, located between internal oblique and transverse abdominal muscles. Then from roof, which is formed by the same muscles, it is slided into the channel. Look, not from deep ring, from roof. And inside of this channel, it is innervated all 4 walls. Because if during the surgery you will damage this nerve, it will make the weakness of weak place, because you will then have big After you know it has come to outside, gives the branches to the genitalis, and finally come to the upper third of the femoral region, medial surface. Remember, ida inguinalis, ida hypogastrica, ramus femoralis, nervi genitofemoralis. What is the second key structure in the male's spermatic cord? That's a male's, by the way, heart structural unit. It has 3 membranes and 10 structures inside of these membranes. So then we say spermatic cord, we understand that this is collection of structures. It's not a single structure. Inside of it we have arteries, which I will represent it for you, veins, nerves, some remnants, and one duct. Arteries, veins, nerves, one remnant, and one duct. What is located in females channel? Now 4 structures. First of all, biggest one, it is the round ligament of the uterus. Another 2, it is the nerves. This is the inguinal one and ramus genitalis, nervi genitofemoral. You can see there is the male's genitofemoral nerve inside of spermatic cord. After we'll discuss. Females, of course, doesn't have it. That's why it's located immediately inside of the child. What is the last structure, 4th one? That is the remnant, which I mentioned inside of spermatic cord again. We call it remnant of vaginal process. The most important structure, which is support descending of the testes, which is organize these physiological processes. But after the child was born, these open vaginal processes sleep, and instead of the vaginal process, we have its remnant. Little after I will introduce it for you. Again, for males, it is inside of spermatic cord. For the females, it is just inside of the channel. So if females has 4 structures, male only 2. But inside of second one, there are 10 structures. Is it understandable for you? That is more than simple, friends. Remember body. Let's continue. Okay. Now attract your attention, please, into this picture. Do you know what is it? This is same anterior wall, but from inside. Imagine that you enter inside of peritoneal cavity, you look to front, and you see inner surface of anterior wall. Yesterday, last time, that we discussed the layers, we come to the conclusion that the anterior wall has 7 layers. First, skin, last 7, parietal peritoneum. Now, then you discuss it from inside. Your first layer will be parietal peritoneum. Your last layer will be the skin. By the way, in this picture, there are one big difference between right and left sides. Right side, keep this peritoneal covering. Left is draw without it. And you see the transverse fascia and Langenbeck space, which is located between parietal peritoneum and transverse fascia. As a painter, just don't draw it to show what is located in front of parietal peritoneum. But now attract your attention, guys, into these folds, into these depressions, which is located between these folds. As you can see in the picture, there are 3 folds in each side. By the way, from these 3 folds, one is single, another 2 is double. All these folds we call umbilical. Umbilical. Let's name them. First single one we call plica umbilicalis mediana, the midline umbilical fold. You can see that from fundus of the urinary bladder, it is continuous up to the level of the umbilicus. That is the remnant of the embryonal structure, which is called urachus. As you remember, urachus, it is embryonal urethra, and it forms the liquids which is surrounding the fetus. Let's remember, guys, the structural units which is located inside of your umbilical cord. If you will make the section of the cord, you will see 3 structures, number 1, number 2, and number 3. Embryology, which you studied previously with anatomy, number 1 structure, it is the umbilical vein, single structure. Number 2, it is umbilical arteries, double structure. Number 3, it is urachus. That's a fold which I show for you, midline umbilical fold. It is the remnant of structure number 3. Why remnant? Because embryologically it is open and working. Then it is constricted and become to the full. What is the function? Again, I say the formation of the primary urine, yeah, which is the same to the plasma of the blood. It's not the secondary urine. Is it understandable for you? What is the function of structure number 2, which is called umbilical arteries? Sorry?
Added the alternative blood from baby to the mother.
Of course, to the not mother, to placenta. To placenta, where we have decarboxygenation and oxygenation. Yeah, that's it. Arteries have venous blood. Why? Because this is the vessels which is come from the center to the come from the center to the periphery. You understand me or no? Once again, this is the structures which is collecting the blood and providing to the placenta. Structures which is start from placenta will be the arteries. What is now in our adult your faces? I see that. I open America. You're like the Christopher Columbus now, you know, like Christopher Columbus. You open America, guys. Child doesn't have oxygenation inside of the lungs. Child has oxygenation inside of placenta. Vessels which start from placenta, providing arterial blood. Vessels which start from, which come to placenta, providing venous blood. Because oxygenation happens inside of placenta, not inside of the lungs. Remember, that is so simple. That's why these structures we call arteries. Because this is the structures which is come from heart, vessels which is come from heart. We call finally arteries. Doesn't matter which kind of blood they have. Why that first one we can call V? Because it becomes center. Doesn't matter which kind of the blood it has. Example for you, pulmonary trunk which you have. It is artery, but it has venous blood. Vice versa, pulmonary veins, which is become to your heart. They have arterial blood. But I see like Christopher Columbus now, you open America, guys. That is very sad. Because 3 years you study in medical university. Remember these two structures, please. Umbilical arteries. And now look to these two folds. This is remnants of umbilical arteries, and they forms next fold, which is double, and which is called plica umbilicalis, now medialis. Previous one is midline, this one is medial. Again, I tell you, that is the remnants of umbilical arteries. You can say me, where is the remnant of the structure number 1? It's not completely visible. You can see only tail of it. Remnant of umbilical vein we call round ligament of liver. From right side of your umbilicus, it comes to the hilum of your liver. As umbilical vein for the fetus. From umbilical cord, it is become to the liver. What has happened in fetal time of the life with this umbilical vein? What is happening? This is circulation of the embryo blood. There is your knowledge. By venous duct, it is drained into inferior caval vein. By inferior caval vein, it is go to the right heart. By oval aperture, it is come to the left heart, and it is supply the body. I mean arterial blood. Oh, friends. That's awful. That's awful. You know, except your class, I provided the classes for 6-year students, you know, especially in college. Every year, every semester, I change the lectures. Look, guys, if I will be so much lazy with you, once I will write it, I will forget about any other improvements. But in medicine, it doesn't work. You should read and study every day. Every day. Otherwise, you will be the exponent of the museum. historical museum. And your knowledge will be absolutely unuseful. What are you doing now? Okay, you didn't study these problems previously. Improve now. Try to study, revise, refresh again your knowledge. And again, I see absolutely absent of any emotions in your faces. That is so normal for you. I imagine how you study in your schools. That is awful. Where is your motivation to work? Where is it? Like force, I catch you in the street and put in my room to teach you, yeah, like the strangers from the street. Okay, then once again, remember about this remnant, round ligament. Let's say after the child was born, this embryonal structure, due to the change of the metabolism, due to increase of the oxygen level in the blood, they constricted and they become to the remnant. So a little after we'll remember about it. But let's continue our speech. Where is the last finally fold? In one side it's visible, in another no, because peritoneum is removed. This is last fold, which we call lateral umbilical cord. Let's say plica umbilicalis lateralis. Meaning the tension again. Plica umbilicalis mediana, single, plica umbilicalis medialis, double, plica umbilicalis lateralis, again double. How it forms? If all previous folds which I presented for you, it is remnant structures. This is not remnant, it is absolutely normal vessels, which is located in front of the peritoneum. Now, if in front of my white cord or behind, doesn't matter, will be tubular structure, my white cord, which is covering, will form the fold. But this is normal vessels, which you see in this side of the picture. That's why the painter remove here the peritoneum to show what is it. It is inferior epigastral vessels. One of the deep vessels of anterior wall. After that, my time will be enough, I will introduce it for you. As you remember, our anterior wall has superficial vessels, and it has deep vessels. Let's say this is one from deep vessels. If you will attract now your attention into these folds, between them you will see depressions. Now attract your attention into depression 2 and depression 3. Depression number, by the way, these depressions we call inguinal. If folds we call umbilical, depressions we call inguinal. Depression number 2, which is between the last two folds, we call fossa inguinalis lateralis, lateral inguinal depression. Depression number 3, which is little bit lateral to the last fold, we call fossa inguinalis lateralis. Let's say we have lateral inguinal and we have medial inguinal. First one we call supravesical. It is above the urinary bladder. But attract your attention into these two depressions, second and third. Now imagine that I make the section of cadaver. I remove this anterior wall. Now I take the long needle and I insert it consequently into second and into third depression. What will be happen? If I will insert it into depression number 3, immediately my needle, after perforation of the parietal peritoneum, will pass through the deep ring of inguinal channel. Because deep ring of inguinal channel projected here in the depression 3. Once again, remember please, deep ring of inguinal channel immediately projected into the fossa inguinalis lateralis. If I will do the same manipulation, but now with depression number 2, after perforation of peritoneum and transverse fascia, through the inguinal space, my needle will become to superficial ring. Muscles will not be perforated because they will lead it upwards. They form the space. So I will perforate in transverse fascia, I will perforate in peritoneum, and then, without perforation, my needle by superficial ring will come into the outside. For males to scrotum, for females to the pubic bones. So right to remember, please, that in the medial inguinal fossa, we have projection of superficial ring of inguinal channel. That's super, guys. We understand now together what is the meaning of these two depressions. So one, it is projection of deep ring. Second, it is projection of superficial ring. Now we need attention, everybody, into this picture. Then we studied together lower extremity. We discussed one kind of the hernia, which is called femoral hernia. And if you remember, I told you definition. What is the hernia? It is protrusion of inner organs through the natural or artificial weak places, which is covered by non-damaged parietal layer of the peritoneum. Because inguinal space by itself, it is also weak. We can have now also protrusion of inner organs, and it can be happen inside of these 2-hour depressions, or inside of depression 3, or inside of depression 2. But I have a question. Why not along of all these inguinal space? Why immediately in the level of this depression 2 and 3? Because we say that generally weakness has all these inguinal space, not only the part of these depressions. But why then much more usually hernias will be formed immediately inside of these two depressions and not between them? Because inguinal space will pass between these two depressions, because spaces started from that level and come to this one.
Deep and superficial rings. Because of the deep and superficial rings.
What does it mean? Because of deep and superficial ring?
The deep ring is, it's like a defect in the transverse fascia. So
Superficial one, it is defect of external or lithocanalosis. So she's absolutely right. By the way, great answer. She wants to say that, yeah, of course, inguinal space is weak, but it has more weaker places. Because 2 another layers will be absent in the region of rings. In the region of deep ring, we will have absence of transverse fascia. In the region of superficial ring, we will have absence of external or lithocanalosis. That's like if I will be organ which need to be protrused, I will choose these weakest weak places, because I will make less pressure to be protrused. Is it understandable for you? The more layers is absent, the more weaker become the space, and vice versa. There's a completely all inguinal space is weak, but especially in the region of these two depressions. Because in the depression 3, transverse fascia more will be absent. In depression 2, external lithocanalosis will be more absent. More I means added to the absent 2 muscles. Is it understandable? Friends, nobody in the whole universe, we don't have medical universities. In our planet, be sure didn't explain this topic in such a way as me. Use it, friends. Use it. You're a happy person. Nobody didn't explain it like I explained it to you. Use it. Now look to me. Let's imagine that protrusion is happening inside of the depression 3. Which characteristics will have hernia? Look to me. Is it possible to come to me? Thank you very much. Stand up, just in this side, and raise your left hand to me. Very well. Now, his hand, this is parietal layer of peritoneum. And his hand, as you can see, have depressional form. Behind of his hand, I put the channel. Immediately in the level of his hand, I put the deep ring of inguinal channel. That's why his hand will be fossa inguinalis lateralis, structure number 3 in our picture. Is it understandable for you? My fist, it is organ, which is want to be protrused. If this protrusion will be happening in the level of fossa inguinalis lateralis, immediately after the pressure of parietal peritoneum will form the sac of the hernia, and it will be entered into the deep ring of the inguinal channel, together with content. My hand is content. Of course, we cannot insert it our hands inside of this narrow tube, But let's imagine this mechanism. After this, my friend's hand, together with my hand, will pass through this channel. But don't forget that this channel has oblique direction, which I described for you before. It passes from up to down, from lateral to medial, and from inside to outside. Remember forever, such kind of hernia, which is originated in depression 3, which is passed from deep ring, and which is directed to the channel, called oblique or indirect hernia. You know explanation why it is oblique, because it passes inside of the channel, which has oblique natural direction. Thank you very much, but you don't finish. If there are somebody who didn't understand it, please honestly raise the hand. I will explain it once again, honestly. Thank you very much. Thank you very much. Now look to me, everybody. My friend's hand, it is parietal layer of peritoneum, last layer of the wall. In front of his hand, there are 6 another layers. And immediately next layer, it is transverse fascia. Transverse fascia perforated in the level of his hand, and this perforation we call deep ring of inguinal channel. Friends, I especially explain it for you because your gray matter has big problems. Try to listen me now, please. Yeah, it's not funny here. It has really, I think that it has the problems connected with degeneration. So try to listen to me attentively. Now look, once again, this transverse fascia perforated here. And this perforation located immediately in front of his hand. His hand covered this perforation. If I will press now his hand from inside to outside, as the organs press it during herniation, his hand will be protruded and will form the sac of the hernia. My hand will form content of the hernia. And we together will be enter inside of the deep ring of the channel. But if I will be enter inside of deep ring, I should pass through the channel. But because this channel has oblique direction, I will be called indirect or oblique hernia. Because my movement will repeat the movement of this channel. If again you don't understand, sorry, I'm not responsible to help you. Now, dear friend, put your hand in level of superficial ring. Again, make the depression. Thank you very much. You are so smart. Now look here, please. Now his depression, it is depression 2, fossa inguinalis medialis. And his depression located in the level of superficial ring. By the way, between superficial ring and his hand, we will have transverse fascia, which is not perforated now, which is absolutely normal. Then I will make now pressure of his hand. Again, he will form the sac. Again, he will come to outside. By the way, he will not be so big like a oblique, because in front of him will be one wall, which is called transverse fascia. But finally, he will be protruded immediately in superficial ring of the channel. It means he will make straight movement. He will not pass through the channel.
Directly from that.
Yeah, of course, dear friends, such kind of hernia will be called direct hernia. Thank you very much. You are really helping. Is it understandable for you? Why it is direct? Because it doesn't make any oblique movement. It is passed from deep to superficial. Only one directional movement. If previous one passed from up to down, lateral to medial, inside to outside, now you have movement from deep to superficial. Friends, I don't know how more I can explain it for you. Conclusion is simple. Inguinal hernias can be originated inside of 2 depressions, into the medial and into the lateral inguinal. Hernia which is originated in lateral depression, we call oblique hernia, not deep, oblique. Hernia which is originated in medial protrusion, we call direct inguinal hernia. Again, friends, I will not speak about hypertrophy of your gray matter. I promise you. who didn't understand, raise your hand, please. Everybody understand. Dear my friend, you please, tell me how we will call the hernia which will be originated here. Inside of depression 2. You're cheating, friend. Keep for your relatives, okay? Keep your cheating for your relatives. Then you will go to your home, told them that you have stupid teacher who didn't teach anything. That's why you are sterile. Maybe they will accept this cheating. I don't accept it. Okay, you remember, if you want, write, please, what you should tell to your relatives. Write to remember. Say that university is rubbish, together with the teachers who work in that university. That's why we don't have any knowledge. I'm very sorry, guys, but I cannot explain it in any other way. You even don't understand which emotions I have now. Why you don't say that you don't understand, friend? That's all. That is completely awful. I don't even find any English terms to explain now how I feel. You know what the problem? My time is very, very short. I cannot repeat it 75 times the same, but if you will not understand this, all another my explanations will be absolutely ununderstandable for you. Why, friends, why you are so big? Why you choose something which is not interesting for you? Again, I tell you, hernias which is happening in second depression, which is called medial inguinal, we call direct, because without passage inside of the channel, they immediately come to outside by superficial ring. Hernia which is originated inside of third depression, we call indirect, because after the origin, it is immediately enter into the deep ring. It is passed through the channel which has oblique or indirect position. And that's why it's called indirect. Now tell me please, how you will call the hernia which is originated in third depression? Why? I will now insert it my ear into your mouth, sorry. Speak loudly, please. You appreciated this situation, friend. She's so, so beautiful emotions she has. They're fantastical. So remember, once again, anatomically, all inguinal hernias divided into these two mentioned types. So we have indirect and we have direct inguinal hernias. Clinical classification is another, and you know I gave it for femoral hernias. Hernias can be divided into three types: reducible, non-reducible, and strangulated. Let's say we have clinical classification and we have anatomical. I don't have time now to refresh you what is reducible, what is non-reducible. Open your previous topics and study. Just I want to tell you guys that for formation of any pathological condition, you need to have two types of the factors. One factor we call etiological. Second, we call risk factor. Now, what is the etiological factor for formation of any hernia? It is the weakness of the weak place. Don't say it is present of the weak places, because everybody has it, but we don't have the hernia. So we need to have the weakness
Of the weak place.
What is make weaker our weak place? Different diseases, different traumas, different surgical manipulations, which is violated, which is, for example, destroys supply, innervation, anything. Risk factors divided into two groups. Look, it is predisposing and executing. Predisposing factors, it is factors which is possibly made weaker weak place. For example, vasospasm. For example, problems connected with innervation. For example, some sport which is actively damaged the regions. What is executing factor? High pressure inside of the pericardial cavity. If I will take something heavy, I will not have any heaviness because I have enough protection. But if my enough protectional forces, powers will be depressed, executing factor which is high pressure, why it can have constipation, heavy physical work, cough, anything which is increased the pressure. Together, these predisposing and executing factors can miss remission of the problem if there are weakness or weak place. Do you understand it or not? Super, I'm happy. Let's continue. Now we need attention, everybody, to me. And let's start to speak about the distending of the testis because it will explain for you the biomechanism of formation of the inguinal channel. Now look please, everybody to this slide. Our testis, friends, originated not inside of the inguinal region. Our testis, as for you, round ligament of the uterus, originated in retroperitoneal space. That is the level of first, second, lumbar vertebrae. What is retroperitoneal space? It is space between transverse or endoabdominal fascia and parietal peritoneum. From backside you have transverse fascia or endoabdominal. From in front you have parietal peritoneum. In anterior wall, position is changed. Fascia come to in front, peritoneum located behind. Look between my two hands, guys. For you everything is hard. But look please here. One ring I draw by green, second ring I draw by red. This is anterior wall. This is posterior wall. This is retroperitoneal space. This is Langerbeck space. They continuation of each other. Just last space is bigger than the first one, but both is formed between the same structures. One green one, it is fascia. Second red one, it is the peritoneum. In anterior wall, fascia located in front of the peritoneum. In posterior wall, fascia located, fascia located in front. In posterior, fascia located behind. Use your imagination. That's why your testis or round ligament originated here in retroperitoneal space. And it should migrate it from back to in front, from up to down, and from lateral finally to the medial. Finally, in the level of the approximately fourth one, it should be inside of Langerbeck space, immediately in the level of fossa inguinalis lateralis. In Langerbeck space, immediately in the level of fossa inguinalis lateralis. In that, if you want to sleep, go wash your face. In that time, transverse fascia is not catheterized, it is absolutely normal. In that time, we don't have any inguinal channel, nor any rings of inguinal channel. We have 7 layers of the wall, which we mentioned before. No any inguinal space. Now we need attention. What is happening in stage 1, third, fourth months? 3 processes. Process number 1, testis is formed, it comes to the fossa inguinalis lateralis. Process number 2, parietal peritoneum, here. This is your fossa inguinalis lateralis, approximately here. Look. Look. Parietal peritoneum forms sharp, actively grow structural unit, which is called vaginal process. And one more structural unit is formed. In the place of the future external genitalia, anterior wall is made the protrusion. For females, females external genitalia, for males, males. It is understandable. Once again, first stage, it is three processes: formation of the testis, formation of vaginal process, and formation of protrusion. And testis from up come to little bit to down. What has happened during second stage, 5th, 8 months, as you can see? And vaginal process. Just laterally to me here. What will be the testis? Testis and vaginal process fuse to each other by special ligamentous structure which is called gubernaculum testis. It has two ligaments, one we call scrotal, second we call testis. Now look please, I have vaginal process. Laterally to me there are virtual testes. It is fused with my hand. Now if I will start to actively grow, he will passively come with me. And I will start to grow now in immediately direction of the channel. From up to down, from laterally to medially, and from inside to outside. She is in front of me, transverse fascia, and between us there are Langenbeck space. First, what I will perforate it will be transverse fascia. Then I will perforate it, this transverse fascia. I will form deep ring of inguinal channel. And me, together with testes, will be entered inside of this deep ring. Part of this transverse fascia, which I perforated, will cover the spermatic cord and will form the first membrane of spermatic cord, which is called fascia spermatica interna, internal spermatic fascia. In front of our friend, next layer will be two muscles, transverse and internal oblique. In that time, they completely connected with inguinal ligament. I will so press them that will disconnect these two muscles from inferior 2/3 of inguinal ligament. I will form the space. Part of these two muscles will cover again spermatic cord and will form the cremaster muscle, which is lift your testis up. The wall, which is located behind of our friends, will be aponeurosis of external oblique. Absolutely common layer without any aperture. Finally, I will press this layer also. I will split it into the legs, and I will open the last aperture, which is called the superficial. Now, part of this aponeurosis again will cover the testis with spermatic and will form the fascia cremasterica. That's why three coattings will have this spermatic from out to inside: cremasteric fascia, cremasteric muscle, internal spermatic fascia. Friend, which percent of my speech you understand and recognize? Which percent? 5, 10, 50, 99, 100? Friend, for example, you can be great another specialist. I cannot be responsible to say which specialist. Why medicine? Why medicine? If the medicine, why you are not responsible to listen to me? Friends, again I say you, I told you last time, my daughter now in medical also studying the 3rd year of medical university. Nobody didn't explain them these topics. Nobody. They achieved some yellow papers, historical xeroxes, which is 25-year-old, without any pictures. And by this 25-year-old paper information, they should prepare all these topics. I don't know how else to explain it for you. After go to his room, ask him to re-explain for you. It's not, friend, why any my speech made for you so positive emotions? Yeah, I understand that life generally is beautiful. That is very important points, guys. Now you understand the biomechanism of formation of all inguinal structural units. Everything which in the name have the inguinal term forms due to this process which we call descending of test. And finally, stage number 3, last month of the pregnancy, in that time from superficial ring, finally testes descended into the scrotum. And the process is finished. And then the child was born immediately by first breath. Look to me, layers of this. What is the vaginal process? It is double layer, yeah? I am the peritoneal, I make the sharp process. These two layers slip to each other, and vaginal process is closed. Why? Now look everybody to me. We decided that she is deep ring, then I have the channel, I am vaginal process. Now look to me. Then I am fetus. And then I am located inside of the channel, vaginal process. I have congenital, oblique, double-sided hernias. Why? Because through my this sac, simply content of my cavity, this is my cavity, yeah? And the peritoneum can descend into this channel. As I remember, please, for fetus, starting from the 4th month, oblique hernia is physiological process. Once again, guys, what is the vaginal process? It is something like sac of the hernia. It is protrusion of the peritoneum inside of the channel. But behind of this protrusion, we have organs. And organs easily by this protrusion can be slide inside of the channel. That's a remember forever for the fetus, oblique form of the hernia. It is normal and physiological. Now you understand why by first breathing these layers of vaginal should be slit and closed to prevent formation of congenital hernia. Because if this mechanism will be destroyed, and if after the birth of the child, the layers of vaginal will not be connected to each other, we will have congenital oblique form of the hernia. That's why remember now forever. Congenital hernias can be only oblique. Acquired hernia can be endoblique and erect. Is it understandable for you? Don't speak stupidly about congenital direct hernias. It cannot be exist. Congenital hernia can be only oblique. Can you repeat what I said just now? Why? Say God's no. It's a good option. Say God's no. If not God's no, explain me why. The shoulder movement, it means God's no. Yeah, so my option is not bad. Believe me. Say God's no. I like you very much. You are very good friends, but you are unimproved. That is impossible. That's why I will finish to say you anything, because I see that it's impossible to influence into you. You know, if I will compare you with some anatomical structures, which is grow, yeah, you come to the bony situation. You have the solid bones, which is impossible to change anyhow. See, so show great friends, show some great emotions you have. It's so great to be the bone, yeah, or the part of my furniture. Now, if I will ask my table, response will be same. It is really great, friends. Imagine how you will treat after the patients by such kind of great knowledge. How good social element you will be in your country with such kind of great knowledge. It will give for you so great emotions, friend. I'm very, very sorry, guys. I don't know any other method to influence into your behavior. I don't know. I can kill myself, but if you will not listen to me, it will be not useful, I promise. Friends, then you listen the music, and then you listen the explanation of your teacher. That is absolutely different, 180-degree different situations. Then you listen the music, you do it to relaxate it. You do it to meditate it. You do it to switch off, your gray matter and to be relaxed. But that is not the same than you listen some scientific explanations. That is absolutely not that case. Vice versa, you will make the big mental work. It is not so simple. You will attract all your attention to listen and to understand any sentence of your teacher. I think it is so easy to understand, friends. But you listen to me like some movie or some voices, nature voices, some birds' songs. If you understand it, let's continue. That's I remember forever, guys. Then we speak about congenital hernia. We mentioned the hernia, which is only oblique. What is the difference between congenital and acquired? Number one, congenital one originated immediately after the child was born. Acquired one can be originated in any age. We need the new protrusion. Congenital hernia can be only oblique. Acquired one can be indirect and indirect. Now look in this picture. Tell me please, from these two hernias, both is hernias, yeah? You can see protrusion of the peritoneum, content. Which one is congenital, which one is acquired? Is it congenital or acquired? Is it congenital? How you recognize it?
Because the content is coming along through the same.
Because sac of this hernia fused with the testis. I tell you 2 minutes before that, by gubernaculum testis, vaginal process and testis fused to each other. That's why if it is congenital hernia, sac of the hernia will be fused with the testis because that is natural process which is happening in our embryonal type of the life. Then it is acquired hernia, no any connection. Because this is new protrusion of the peritoneum which doesn't have any relation to the testis. That's why remember please, then we speak about congenital hernia, we say that sac of it is fused with the testis. Then we speak about acquired hernia, we say that no any communication. Yeah, it can descend into the scrotum, but sac will not be fused with the testis at all, as you can see in the picture. Now what the difference is between direct and indirect hernia? The first and main one, place of origin. Indirect one originated in fossa lateralis, direct one originated in fossa medialis. Then indirect originated in fossa lateralis, look please here, it should pass through the deep ring. But you know what is the problem? Deep ring twice smaller than superficial. And deep ring for the males completely occupied by the elements of the spermatic cord. That's like if indirect hernia for the males is happen, this hernia is entering inside of spermatic cord. What does it mean? Imagine that you're a surgeon. You open inguinal channel because you know that indirect hernia located inside of it. You will not find any hernia until you will not cut trim and break your spermatic cord. Because again I tell you, indirect hernia, due to the small size of this ring, immediately enter inside of spermatic cord. External ring is bigger. And medially to the spermatic cord, there are enough planes that a hernia pass through the ring, doesn't enter inside of the spermatic cord, and located a little bit medially to the spermatic cord. Division number 3, or difference number 3. As we modulated 2 minutes before with our friend, indirect hernia usually much more bigger and much more easily descending into the scrotum because in front of it, no any wall. For direct hernia, that is not so simple because transverse fascia don't have braiding covering from in front and says, friend, stop. Stop please, don't be so big protrusive. That is one more difference which we have between these two hernias. If you make, for example, ultrasound investigation and attract your attention into pulsation of inferior epigastral vessels, yeah, by sonographically you can by Doppler you can detect it easily. For indirect hernia, this pulsation will be located medially to the sac of hernia. For direct hernia, it will be located laterally. Because fossa inguinalis lateralis located laterally to plica umbilicalis lateralis, but fossa inguinalis medialis located medially. That's why we will detect this pulsation differently. Final difference. There are the special diagnostical method, physical method, how to recognize and understand which hernia is it. We call it cuffing sign. You take your finger and through the wall of scrotum or through the wall of the external lips, you insert it inside of superficial lip. And you ask your patient to cuff. Because then the patient will cough, pressure in peritoneal cavity will be increased and more content will come to our side. Look, you can feel now attachment to tip of your finger or to side of your finger. And you must understand what does it mean. If you feel it by tip of your finger, which kind of hernia is it? Oblique or direct? Why?
Because it's coming through the channel.
So smart person. Guys, to be so smart. Listen me, she's also, has one head, neck, all another part. Why she can, you know? Because she know that this is necessary for her future. Yeah, she is absolutely right. If my tip of finger located inside of the channel, it can be contact only with oblique hernia, because no any other hernia doesn't pass through the channel. If side of my finger contact with the hernia, it means this hernia doesn't pass through the channel. It's immediately come to outside. Such kind of the qualities has only direct hernia. No, thank you very much. Do you understand this, guys? That is more than simple. Just use your brain. I finished to discuss anything connected with the hernias. Now let's become again to the spermatic cord and let's speak quickly about the structures of it. Don't write, guys. So you like to write everything. It is so sad. Everything is given here. Listen. As I say, spermatic cord, it is hard structural unit which has 3 coverages. You can see middle coverage is red. Why? Because it is musculus cremastoid. 2 others is pink. Why? Because it is fascious. From outside cremasteric, from inside spermatica interna. And all origins I give you before. What is inside of it? I say you vessels, nerves, 1 remnant and 1 duct. Biggest structure it is ductus deferens, which is evacuated sperma from the testis and provided to mid part of the urethra inside of prostate. And often second structural unit, it is remnant of vaginal process. If for females it is just in the channel, for the males it is inside of the spermatic cord. That's why again I say you, if will be for example congenital hernia, if this will not be open, you will find it inside of spermatic cord. And generally any oblique hernias will be inside of the spermatic cord. Doesn't matter is it congenital or acquired. Another third group, it is arteries with veins. Testicular artery, ductus deferens artery, and cremasteric artery. Testicular from aorta, through ductus deferens from internal iliac artery, and cremasteric from inferior epigastric, which I show for you. Veins of testicular artery we call plexus venosus papilliformis. Plexus venosus papilliformis can be enlarged only in left side. Because left papilliform veins drain into the left renal vein, right drain exactly in the inferior column. And inside of renal vein, especially in puberty, we can have high pressure due to the renin-angiotensin mechanism regulation. If inside of left renal vein will be high pressure, we will have not enough drainage from left testis It will enlarge these plexus venosus, and this pathology we call varicocele. Varicocele. Don't explain varicocele in right side. It's not happening. Only in left. Due to the specificity of the venous drainage. That's why I described for you until now the arteries and veins. That's why once again, 2, 3, 4, 6 structure. 7th structure, it is lymphatic vessels, which is drain your testis, ductus deferens. 8, 9 structure, it is the nerves. 8-1, it is sympathetical, parasympathetical nerves, so ductus deferens and testis. And finally, last one, it is the, as I say, ramus genitalis, nerve genital. That's all. For females, it is just inside of the channel. For males, it is located inside of the spermatic column. Scrotum. Inside of the scrotum, friends, all layers, it will be the mimics of the layers of anterior abdominal wall. Because what is the scrotum? I said before, protrusion of the wall. That's why skin is skin, fat we call tunica dartos. Why? Because it contains smooth muscular fibers. That's why our skin of the scrotum can be vegetatively constricted or dilated. First, for example, due to temperature change. Layer number 3, it is vasta spermatica externa. Remember, it is originated from the Thompson fissure, deep layer of the superficial bone fissure. Layer number 4, it is musculus cremaster, originated from internal oblique transverse. Layer number 5, vasta spermatica interna, from transverse fascia. Layer next, last layer, it is tunica vaginalis, from parietal peritoneum. It has 2 layers. Visceral fused with the testis, parietal, no, between them there are cavities. That's all. Oh, no. Now vessels and nerves. In anterior abdominal wall, as I told you before, 2 groups of vessels, superficial and deep. Superficial lymphatic tissue divided into 3. Epigastrica superficialis, circumflexa, pudenta externa. All of them I described you, then we study femoral region. Inside of the fat, there are a lot of the veins, and they belong into 3 venous systems. Above umbilicus, we have veins which is drained into superior cavum. Below umbilicus, into inferior cavum through the femoral vein. And right side to umbilicus, I show for you round ligament of the liver. Inside of this then umbilical vein, structure 1 is compressed. It's not compressed completely. Inside of it, there are open working several para-umbilical veins, which is drained into the portal venous system. So, 2 anastomoses will be forming fatty tissue, cava-caval between up and down located veins, and portal-caval between all these caval and portal. If inside of portal system will be high pressure, we will see shunt of the blood from portal to the caval, so-called caput medusa formation. All these anastomoses will enlarge like the snack of the heroical dispersion from Greek epos. Deep vessels and nerves is much more complicated because they are located in 3 different places, not in one like superficial. First one, it is between internal oblique transverse. Here we have 6 inferior intercostal neurovascular bundles from 7 up to 12. Here also we have 4 pairs of the lumbar vessels, which is come from aorta abdominalis, supply lumbar and anterior wall. Here we have also nervus inguinalis, hypogastrica. Both I explained for you. Inguinalis through the roof entering the channel, supply come to femoral region. Hypogastrica, perforated muscles come to fatty tissue, supply the skin below umbilicus, and again give the branches to the femur. Second place with deep vessels, it is Langenbeck space. Several minutes before I told you that in Langenbeck space there are 2 arteries. It is epigastrica inferior, which is for the lateral fold. Plica umbilicalis lateralis, and circumflexa iris profunda. In fact, we have circumflexa superficialis. Both originated from iliaca externa. It is the primary part of femoral, above umbilical, above inguinal fold. We call it iliaca externa, below we call it femoralis. But what is important, look to here. Inferior parts of inferior epigastral artery you don't see, but superior you see. Why? Because it is perforated transverse fascia and come to the sheath of the rectus muscle. That's the last place of location of deep vessels in the sheath of the rectus muscle. From up to down, we have superior epigastral. From down to upwards, we have inferior epigastral. There veins also for anastomosis, which is covered up. Now, very quickly about rectus sheath. You remember from anatomy that there are two structural types, above and below umbilicus. In my previous lecture, I explained it for you. You remember above umbilicus and in front and behind we have the aponeurosis. Below umbilicus, in front aponeurosis, behind. Immediately here, behind of it, there are transverse fascia. And arteria epigastrica inferior will perforate this transverse fascia, and from Langenbeck space will come to the rectus sheath. That's all. Friend, I don't know what to do. Next, what I will do for you, I will come to your home, I will explain before you're sleeping these topics for you.